a diverse range of presentations that have taken you through multiple areas of implementation science and how it can be used. I'm really interested in the clinician that just asked the question about using process mapping and whether Sian's presentation inspired you to take that next step, but I won't put you on the spot. Yeah. Pre-contemplative. Are there any questions for any of our speakers? I have some. Okay. Chair's prerogative. Yeah. Tell me again, there were strategies. How many strategies?
11 strategies.
11 strategies. Yeah. And then there were the barriers. So how did you match those strategies and those barriers?
I think that's an interesting point across the board, right? When one of the key aspects of implementation science is looking at across projects, right? What are the key barriers? And in Sian's project, it was around, a survey. That was one way that it was done, In Natalie, we surfaced the barriers with process mapping, along the clinical pathway. And in this project at the policy level, it was from policymakers and like those stakeholders at different levels. So the sources of barriers can come from different sources, right? But then how we actually think about solutions is quite similar across the board, right? We really have to think about what's the gap that we're trying to solve, like what is the problem, the challenge. But then again, prioritizing those barriers, because you can generate a wide range of barriers, right? And in Sian's study, you had like 25 or something barriers, and then in the end, she highlighted that she selected 5 or 6 for intervention because those were the most prevalent, which makes sense across the board. And it's a similar approach to what we did, which was handpicking with the feedback of the team, of course, which were the top priority barriers. So that is the first step, really, is to see what are the key ones that we need to focus on to make the most impact. And then when comes the time to actually select strategies, you have the ERIC taxonomy that Sian presented, and we've used in that project, right, that provides a list. It's a grocery list of 70 strategies, and we go through the list, and we see there's a tool called C4ERIC that I've mentioned that's easily accessible online, and you can see experts in implementation science have actually matched, the strategies themselves. So if you have, for instance, just lack of knowledge, what would you do? Of course, you would do training, right? Education. So that makes sense. But they've done that exercise for all types of barriers and strategies, so you can use that resource to guide you in the process of making those decisions. So that's one source of information. The other source of information is we actually know that some strategies are more effective than other strategies to support change. And at a foundational level, we know that education works, right, to enhance knowledge and skills, but we also know that, for example, audit and feedback works, right? Auditing clinical data and providing direct feedback to providers. And there's a Cochrane systematic review that we just published that shows a median improvement of 4% in compliance with desired clinical practice across 300 trials of audit and feedback. That might seem small sometimes as an increase, but when you do it at scale, for example, they've done audited feedback for a physician who prescribed antibiotics in Ontario, right, across the whole province. So when you scale up a strategy like audit and feedback at a larger scale, then it can have quite significant, and over time, right, as well, it can have great impacts. And then champions, for example, local opinion leaders that you designate in a clinic as well can have 11, I think the latest Cochrane review is on average 11% in compliance with desired clinical practice with champions. So we know that from evidence that some strategies work better than others. And then the last piece of the puzzle is bringing in clinical experience and intuition, right? And our knowledge as clinicians and researchers. So it's really using those 3 different sources, what experts in implementation science say, what evidence says works, and what theory says, and the clinical experience as well, to come together as a group, to make those decisions about matching strategies. And that's really what we did in the policy process, the first study.
Yeah. I'm interested, Nat, are implementation scientists born, or can they be made? Because that's a lot going on there.
Oh gosh, I don't know. Sometimes I just think I'm an all right project manager who just, is good with people.
Yeah.
And, I think if you want to organise the chaos and you like figuring out structures and ways in which you can do that, like some of the frameworks that Guillaume mentioned, then that's a good starting point. I think you've got to have a passion for it. I think, earlier projects that I did, which did achieve like fast change in hospitals because you're working one-on-one with a few teams across, a smaller amount. I remember my supervisor saying, was it the theory or was it just that you were really enthusiastic? And, managed to, kind of galvanise a bunch of people. And so I think, as part of the science, really trying to test that, really trying to isolate, different components, what the theory, the process mapping, like which of these things actually really make the difference, and can you get all sorts of different types of people to apply them and have the same effect.
I mean, one of the things, we were at a meeting together a couple of months ago, and the process mapping, I think, is just such an interesting process. Excuse the pun. But is the process mapping in itself an intervention that leads to change?
Yeah, and I think that's something that we really want to try and delve into because obviously, people do process mapping in hospitals all the time, just as an isolated activity. Maybe they attach their audit data to it. Does that make a difference? So you see the process, then you attach your data, and you see a gap. There's a bit of audit and feedback in there. And then if you take it one step further and you show them the barriers that align with where those gaps are, how much of a difference does that make? And then on top of that, if you design strategies that align with those barriers, then how much more of a difference does that make? So when you're talking about hard and fast, we really want to understand, well, what's the optimum gain that we can make with the use of something like process mapping, as a 5-stage process. If just seeing it with some audit data is enough to make a 4% change, then do we need to go any further? Do people intuitively then know what to do once they've seen the gaps?
Yeah. Mim, can I ask you a question without notice? Your model was process mapped, wasn't it? Or you were notified there as a... No, you weren't. Combi Clinic was up there. Yeah. Did seeing the process map change anything?
Well, I don't know that we've shown them.
Oh,
yet.
jeepers. Oh my gosh, quick, did you take a photo of that? Yes, good. Well, you can have a look at it. It might change your practice.
So we consented all interviewees, I promise.
Yeah. So you will be feeding those process maps back.
Yeah, and I guess obviously, as there's ways in which you can apply process mapping in a very small scale, hospital by hospital or clinic by clinic, which we do all the time in many projects. But this particular project, we're really trying to understand, okay, first of all, let's collect all the information, let's understand what people do. If we give it back to them, we might, depending on the trial design, we might influence the trial outcomes. So we're really trying to be careful in what we do show before.
So don't look at it.
No.
It's just a concept. It's just it just appeals, that sort of process mapping. It just appeals to clinicians, I think.
It really does, and I think that's why I've really spurred on with it, because I've realised when we're in the room with the clinicians, they often really engage in a way that's different to just trying to have a chat.
Yeah.
As part of a formal interview.
Yes.
But if I'm allowed, I think some of the things that you were saying and talking about, trying to achieve things quickly, I think, you've obviously gained from a clinician perspective, you have all that tacit knowledge as a clinician, you know your patients, you know the system, but then you've gained this additional implementation science knowledge, and that's really helped you to take things so much further. But that's a lot of work for a busy clinician in the system. So I do feel like it speaks to, well, there should be more embedded implementation science in the system so that there is that support, so it doesn't just fall to the clinicians all the time, because it's obviously a lot of work.
Yeah. Does that exist in the world? No.
No. Well, maybe
Okay.
maybe some places it does, but it's not in Australia.
No.
I think, I don't know how it is in the US, so maybe you can talk about the US next, but we do have to think, I think thinking about, you do have collaboratives of implementation scientists, right? Which Natalie leads one in Australia, where it's a group of implementation scientists that works in collaboration with the healthcare system to solve problems. So, the problems are kind of fed through a pipeline, right? And I'm talking about what you do, but you can, and then you also have, I see implementation practitioners everywhere, right? Not everyone does implementation research, but everyone does implementation practice. And what I've done in Canada is, in my hospital system, is to map out who are those implementation practitioners that are actually supporting change within the healthcare system, within the community setting as well, and start to develop those links and start to develop a community of practice and sharing tools and resources as well. So I do think that we have a number of those. They're not called implementation, scientists or whatever, but they have different titles, evidence-based practice advisor, or something like that. So we have to, I think, find those people and engage them as well and leverage them as part of different projects also.
They sound like quality improvement. You could sort of twist them a little bit, couldn't you, and give them other frameworks?
Absolutely, and I think also trying to understand how to better collect information about what they've done in a way that's standardised, as Sean was saying, so that the language is the same, that helps you to understand the patterns.
Yes.
Yeah, I think there are so many people that are implementing programs all the time, right? Our frontline service providers, they see problems and they're addressing them. But not everybody will have the benefit of being in an academic institution or having access to a NAT, right? But there is so much value and so much to learn from our frontline providers that are implementing programs, so that whatever supports we can provide. So again, have everybody using this language, right? So that we can all learn across the board. Frontline providers implementing programs, NATs creating amazing process maps, right? And I think over time, we'll find a middle place, right? And I think there's a place for everyone in implementation.
Yeah. And that's where your program is so important, isn't it? Because it's really showing people at the front line what it actually looks like. Sorry, Kim.
No, just briefly, because, but I was just going to say, I think one main challenge is enhancing the accessibility of implementation science and its usefulness for everyone, right? And the reach, and because there's many frameworks. We've done a review of all frameworks. We've identified 614 implementation science frameworks dating back to the 1930s, starting with action research and it's got the whole discipline, right, that goes back many decades. But how do you, and actually a small subset of frameworks are used consistently, many of those that we've shown today, but how do we enhance the usefulness of implementation science, I think, is a big challenge. But something that Natalie is working quite a bit, I'm also very interested in, is how we use implementation science and AI in conjunction, right? Like, you can go tomorrow on ChatGPT and ask, develop me an implementation plan based on implementation science frameworks, like if you were, an expert implementation scientist, and they're going to provide something that's probably 80% as good as what an expert implementation scientist would have done, right? So you can already use those AI tools to support in implementation planning and some of those measures as well. But I think that's another really interesting area to explore.
Yeah, and then there's that really important next step, isn't it? Of what do you do next? You can have the plan that ChatGPT gives you, but yeah, what do I do next? I suppose you could ask ChatGPT that question. What do I do next? It'd probably tell you. My 12-year-old has told me that ChatGPT is a woman. It sounds like his mother. So yes, isn't that nice? Are there any questions from the floor? Good on you, Jason.
I wouldn't want it to be silent, right? I guess it's kind of going back to the question that was raised earlier. I think it's, first of all, amazing talks. If you think about next steps, and first of all, it's great to see so many healthcare providers here. And I think the therapies are pretty easy now. The interventions are there. We kind of are getting to know how to use them a bit, or at least get familiar with them. The key is now is I think for healthcare providers is how to implement them, right? So it's the stuff you guys have been talking about today. And so I guess I'm just sort of curious, and I think where it struggles is that exact point. We want to get it done now. We don't have time to wait for a year to do all these complex process maps. And I think where we're sitting is that I think healthcare providers actually need a quick and easy way to implement these, like an instruction guide or a manual or training in how to do this kind of stuff. So I'm just sort of curious as to your guys' thoughts around what's next, and how do we do this, and even maybe within THU, it's great that you guys organize this session, and maybe a little plug for those that do like the implementation science. I think there's a more hands-on workshop tomorrow that is being run. So if you're keen to actually learn how to do a quick and easy one, you can go tomorrow. But thoughts on that, I guess, of what can we be doing? Maybe it requires some dialogue from people in the audience as well. Maybe if anybody wants to say what they think as well. But yeah, thoughts.
Well, I guess from just the simple perspective, we can provide training. So I've done some research to try and understand the impact of I guess an initial training workshop, but then ongoing coaching for healthcare professionals in the system. So you kind of hold their hand at every step. You give them the tool, they go and collect the data that you need to understand the process or the barriers or whatever it might be. And then we as the researchers can synthesize that information and then provide it back in a way that it makes sense to a healthcare professional so they can go and do the next step. So, I mean, I know things need to be done quickly, but I guess, over, 6, 12, 18-month period, you could have this partnership where you're providing that kind of training and analysis expertise, feeding back the materials in a way that is accessible. But you've got those people in the system who know exactly what's going on. They can easily access the data, whether it's audit data or, their peers to discuss things with. And then also have a really good understanding about how feasible and practical and impactful a particular strategy is going to be to address that barrier that you've defined as really, important. So I think that's one way. But then there's probably, kind of variations. You might be able to just kind of have an online toolkit, which we have, and, access that. And then once you've done a project, you've gone through the whole process, then it's kind of like lift and shift, apply it in a different context. That's exactly how I've learned, and that's if people have the capability and capacity to do that, and then maybe they start to really enjoy it. But the most important thing would be to try and ensure that everything that's done is recorded somewhere. So even if it's a small report, just so that we can try and understand the process that they've been through and the, the kind of key learnings, because really in the end we're trying to think about, as a science, how do we synthesize all this information so that we can then go, all right, to give you a head start, we know that from 50 studies in this context, with this population and this intervention, these are the key barriers you're likely to face. These are the key strategies that we've got evidence that show that they work, and this is exactly how you operationalize them in that context. There you go.
Yeah.
And this is how you evaluate it.
Yeah, I agree, Nat. And I think it really depends on what your goal is, right? So if you're a busy clinician that's like, I just really want to put some structure and systematic approach to implementing my program, there's so many online tools, right? There's cifra.org. You go in there, you can find this is a quantitative survey. These are the questions you ask in a qualitative survey. Guillaume mentioned the tool where basically you put in your barriers and it will help show you the strategies that are most effective for addressing your barriers. There's reaim.org. So many practical tools available out there for those that are like, oh, I want to get a little bit more in depth. So I did a 9-month training through the NIH, which was, I think, a session a month. But honestly, I think most of what I learned was actually through the doing, right? Through the doing, and, piggybacking on what Nat said, for THU, if, there were interest, having implementation scientists available that could provide support, where people could be like, hey, here's my problem, this is what I'm thinking, oh, what is adoption again? I think that's also an additional approach.
Yeah, absolutely. Guillaume, did you want to?
I think one of the future directions is having more adapted local models for different settings and implementation science models for different settings. So someone, for substance use care, we have a process model that how we usually go, different steps for enhancing the delivery of that model of care, right? So I think going forward, it'll be also thinking about which model can we make our own, for our own context and reuse over time, right? And iterate and improve on it. So I think we're going towards more localized models and frameworks for implementation science. And there's many, many accessible resources, like Sean says, and I think the field is moving towards rapid, more efficient approaches. And, a TDF, a theoretical domains framework, or CFIR survey can take a few minutes to fill out and provide just a structured way of looking at those barriers and facilitators, and doesn't take a lot of effort or time. And then that can really inform decision-making after.
I think the obvious next step is that you all go to the workshop tomorrow. It's at 11:45. It's upstairs in the Verve, and that's where you're going to start this journey of learning and adopting implementation science. So we'll see you all there. Thank you so much for a fascinating discussion and fascinating presentations. So please join in thanking my speakers.